Very good afternoon to all of you. I'm Dr. Pramod, and on behalf of the Department of Geriatric Medicine, I welcome you all to the CCR, a disappearing appetite. So, in this we'll present an interesting case of elderly patient with anorexia. So usually, anorexia is a symptom which is neglected by the older patients. But we, as physicians and geriatricians, we know that anorexia is a red flag sign. Anorexia indicates severe underlying disease, could be a inflammatory disorder, infection, or a malignancy, and it needs to be evaluated. So here we present a case of older adult with anorexia. We'll see how the evaluation unfolds, how the diagnosis is made and treatment given, and how the patient responds to the treatment. So without any further delay, I would like to call upon Dr. Naveen or Jay to present the case.
Good afternoon, everyone. Now I start with the case. Patient is a 77 years male. He is a resident of Delhi. He belongs to nativity Odisha. He is a farmer by occupation. His baseline clinical frailty scale was 3. He had a comorbidities of benign prostatic hypertrophy and chronic eczema for past 3 years. He mainly presented with chief complaints of loss of appetite for 1 month associated with loss of weight, which was gradual in onset and progressive nature. He used to take previously 2 to 3 calories of rice per day. Currently, he is taking only sips of fluids, and it's associated with fatigability and subject to loss of weight. Other associated history, he had a chronic backache for the last 1 year with pain radiating the bilateral thighs. For other relevant history, he had no history of nausea, vomiting, airly satiety, metallic taste, or burning sensations in the mouth. He reviews the history of dysphagia, odinophagia, or other abdominal complaints or jaundice. History of hematemesis, melania. He had no psychiatric complaints like low mood, anxiety, apathy, or headache, confusion, forgetfulness. He had no complaints of cold intolerance, fatigue, constipation for hypothyroidism. He had no complaints of increased pigmentation, postal giddiness, or salt craving. No complaints of fever, night sweats. Past history, he is a known case of chronic eczema for the past days, which was diagnosed outside, and for the same he was receiving treatment from outside. He is a known case of benign prostatic hypertrophy, which was diagnosed outside with ultrasound findings also. He had a past history of left-sided nephrolithiasis, which was operated on 2011. He had no other comorbidities like diabetes, hypertension, hypothyroidism, coronary artery disease, chronic obstructive airway disease, CVA. Personal history, he is a chronic active tobacco chewer. He is a non-smoker, non-alcoholic. His sleep-wake cycle was normal. He has a vegetarian diet. Bladder and bowel habits. He had a bladder complaints of in the form of increased sensation of incomplete emptying of bladder and a terminal dribbling of urine. And his bowel habits was normal. Family history was non-significant. His treatment history include he used to take tablet azothioprine 50 mg BD, tablet hydroxyzine 25 mg BD, topical clobetasol from outside, and some homeopathy medications for which the documents are not available. During admission, we did a comprehensive geriatric assessment. His vision and hearing normal, delirium absent, fall and fear of fall absent, bed sore absent, elder neglect, elder abuse absent. And for detailed geriatric assessment, he had these positive findings of probable risk of sarcopenia with the SARS-CoV score 4, and he was found to have malnourishment with MNSS score of 7/14. He also found impaired mobility with increased TAC score of 18.77, which indicate he was at increased high risk of falls. On examination, during admission, he was hemodynamically stable. His vitals was normal. On general examination, pallor, ictus, cyanosis, clubbing, epidermis, generalized lymphoedema was absent. On head-to-toe examination, in oral cavity, he was found to have a poor dentition and a tobacco staining of teeth was present. A single plaque was present on the medial aspect of left proximal thigh, but it was not associated with any discharge, tenderness, or induration. No signs of dehydration there, and no signs of malnutrition like temporal hollowing, brittle nails, stomatitis, angular cheilitis, they are absent. On systemic examination, periabdominal examination showed no guarding rigidity, tenderness, no organomegaly, bowel sounds present. On other examination of cardiovascular examination and respiratory examination was normal. On CNS examination, his higher mental function was normal, cranial nerves intact, motor examination showed normal. On power examination, he was found to have a bilateral low yielding power was reduced 4 minus by 5 out of 5. His D-terminal reflex was normal bilaterally. The angle Z was 1 plus, which may be normal in elderly. His sensory examination was normal. He had no signs of cerebral dysfunction or autonomic dysfunction or no signs of meningism. So in summary, yeah, 77-year male, known case of chronic eczema papulosis and BPH with the paucity of left side and nephrolithiasis. He presented with a complaint of a progressive loss of appetite with the loss of weight and fatigability for 1 month, associated with the history of a chronic backache. And the treatment history, he received tablet azothioprine, hydroxyzine, topical clobetasol, and some homeopathic medications. On examination, he was found by a single plaque on a left proximal thigh. And other than that, his systemic examination was normal, except that bilateral lowering power was reduced. So after this, we are working for the what are the possibilities for his loss of appetite. It may be due to a malignancy related, like gastrointestinal malignancies or lung malignancies or lymphoma, or some non-malignant gastrointestinal disorders or psychiatric disorders or endocrinopathies, or some chronic infectious diseases like HIV, tuberculosis, or parasitic infections, or chronic fungal infections, or some advanced chronic diseases like cardiac disorder, renal failure, or neurological disease, or some medication related, or it may be just an anorexia of aging possibility there. For chronic backache with bilateral loneliness, these are the possibilities: degenerative, or inflammatory autoimmune, infectious, neoplastic, neurological, vascular. But according to based on history and examination, it was mainly maybe related to degenerative or some possibility of neoplastic and neurological. So after this, our main differential diagnosis based on history and examination. So for anorexia and anorexia, he may had some occult malignancy, or it may have chronic infection, or endocrinopathy, or it may be just anorexia of aging. The bilateral lower weakness element type of weakness may be degenerative related, or neurologic, or neoplastic related. So after this, we did a baseline investigations. On baseline investigations, his hemogram showed hemoglobin normal, but his WBC was elevated with hypereosinophilia, with absolute eosinophilia count was 6,420, 6,420, which was so indicating a severe hypereosinophilia. Comparing to his baseline hypereosinophilia, last AC count was 10 per microliter. His platelets was normal range, and his urea and renal parameters and liver parameters were normal, and electrolytes normal. ECG shows normal sinus rhythm. H-ray was normal. Other investigations, HbA1c was raised 5.6%, indicating an impaired glucose tolerance. His lipid profile was normal. Vitamin D, folate, and vitamin D was in normal range. Stool routine microscopy was normal. Urine routine was normal. No pustules and no cast or visible cast. X-ray fine done for chronic backache, which showed a degenerative changes, and deaths are done which showed osteopenia. So we worked out for the cause of why this severe hypereosinophilia. So basically, we are looking for the hypereosinophilia with anorexia. These are the possible DDs. Allergic, 6 broad categories: allergic, infectious, neoplastic, immunologic, or eosinophilic disorders, or endocrine. Allergic, example, asthma, allergic rhinitis, drug hypersensitivity, infectious helminthics, ectoparasites, protozoa, fungal letter, or viral letter. Neoplastic, primary hypersensitivity syndrome, or eosinophilic leukemia, or other myeloid neoplasms. Immunological disorders like autoimmune disorders, sarcoidosis, IBDs, eosinophilic disorders, and endocrine disorders like adrenal insufficiency, hypopituitarism. So after this, we did a parasitic workup. So the stool acid first was negative, microfilaria negative, strong lights negative, orgothatnine and serum Dutch was negative. And malignancy, we did 2 more markers, which was negative, and the peripheral smear showed no atypical cells, and hypereosinophil was there. And for allergic and inflammatory work, allergic total Ig was raised 853, which may be non-specific and multifactorial. And we did Ig specific Aspergillus antibodies was negative. For inflammatory workup, RF ANA Priyanka Sankaran, which was negative. So after this initial evaluation, initial management was started. For loss of appetite, we got a dietitian opinion, and we inserted rice too, since he had a poor oral intake, and the dental review was done for dental hygiene. For hypereosinophilia, we gave a trial of antihistamines with albendazole ivermectin given for 3 days. But after 7 days follow, he had no improvement in absolute eosinophil count, which showed persisting hypereosinophilia. So after that, we planned for further evolution to look for the why is the cause of persisting hypereosinophilia and any hypereosinophilia related tissue damage. So for any end organ damage, for a cardiovascular system, ECG done and was normal, TROP2 was normal. Pulmonary function test was done, which showed no obstructive or restrictive pattern. And central nervous system, for central nervous system involvement with any infarct lesions, we did a MRI print. Now I like to invite Dr. Nidhi, senior resident from radiology department, to discuss further the radiology investigations.
Good afternoon, everyone. I will be discussing the radiological imaging features of this patient. First of all, MRI brain and spine was done. In MRI brain, the MRI was done to look for any secondary changes due to hypereosinophilia. But the patient only had age-related brain, generalized brain atrophy with no significant ventricular ischemic changes. It was also done to look for cause of hypereosinophilia, which could be because of derangement in hypothalamic pituitary axis. But the pituitary was normal in height and shape. The pituitary stalk was also normal, and hypothalamus was also normal. No plastic changes were there in the hypothalamus. Then MRI spine was done again to look for any etiology for the hypereosinophilia, which could be because of lymphoma leukemia. But no mass lesion was there in the spinal or in the vertebral body. Only degenerative changes were there at L2, L3, L3, L4, and L4, L5 levels, causing lumbar canal stenosis. CCT chest and abdomen was done to look in the chest to look for any mass lesion or any secondary causes of hypereosinophilia and to look for adrenal gland lesion. CCT chest was normal, and this was the right adrenal gland, this was the left adrenal gland. Both the adrenal glands were normal in size, shape, and morphology. No mass lesion was there in the abdomen, significant lymph nodes were not there. So imaging was largely normal.
Thank you, Dr. Nidhi. Now I like to invite Dr. Ruben from Nuclear Medicine Department to discuss further the FDG PET whole body.
So the FDG PET scan was done to rule out any occult malignancy. We can see in this PET scan web image. So there is normal physiological distribution of the FDG, while there is a little abnormal uptake in the medial spine. The screen shows markedly increased uptake as compared to the liver, and then there is a focal increased uptake in the left femoral region. So going into the PET CT cross-sectional images, we can see there is diffusely increased FDG uptake in the spleen more than the liver. So since the eosinophil counts were raised, so this can be because of a reactive spleen. And then there is this subcentimetric left femoral lymph node, and in the upper panel of images and the lower panel of images also, you can see this, the lymph node can be because of the ulcerative lesion which the patient had. So it's an infective etiology. So overall, there is no occult malignancy in the PET scan.
Thank you, Dr. Ruben. After this detailed radiological investigations, to rule out hematological malignancy, we further did a bone marrow aspiration and biopsy. Bone marrow aspirate is reported as 2+ blast cells. Eosinophils and precursors were 12%, and no evidence of any lymphoma infiltration. Blood and bone marrow flow cytometry was normal. Bone marrow biopsy was reported as fibrin with triangular hematopoietic elements, and no other lymphoid malignancy changes. So after further evaluation, we got a fine lab parameter of cortisol low level with a value of 3.4. We got that, and which on further we repeated cortisol and a detailed endocrine workup then, which showed that cortisol was low value only 3.26. Other adrenal cortical hormones like ACTH, DHA was in normal range, and his direct reading was normal, and the thyroid profile was in normal range with TSH normal. These lab parameters are suggestive of tertiary adrenal insufficiency, low cortisol with inappropriately normal ACTH. So our final diagnosis was severe hypereosinophilia related to the adrenal insufficiency with lumbar canal stenosis with radiculopathy and osteopenia benign parasitic hypertrophy, malnourished, and at risk of sarcopenia. So after this, we started with the management. For adrenal insufficiency, we started with induction and hydrocortisone. We started and gradually we decreased the dose, followed by which we decreased the dose, tapered, and followed by which oral steroids started. For lumbar cancer with radiculopathy and osteopenia, we started aim on calcium and vitamin D supplementation, gabapentin with NSAIDs for pain control, and physiotherapy. For BPH, we gave him alpha-1 antagonist tamsulosin. For malnourishment, we advised him adequate calorie intake and protein intake. Initially, we gave it through the rice to feed. For probable sarcopenia and at risk of fall, for probable sarcopenia, resistance training exercise for advice, high quality protein intake was advised. For at risk of fall, balance training was advised, gait training, and environmental modification was advised. And we further planned for adult vaccination since he was started on steroids. On further follow-up, after starting steroids, his eosinophil count was his eosinophil count was found to be decreasing range, and it's reached a normal range of 13 per microliter. And his appetite was improved, followed by which his trials tube was removed and oral normal diet started. Now I like to invite Dr. Venkumar, Senior in Geriatric Medicine, to further discuss the review of.
Thank you, Dr. Navi. Our patient had hypereosinophilia. So before moving to the different causes of hypereosinophilia, I would like to clear some commonly used nomenclature. Eosinophilia is defined as absolute eosinophil count of more than 500 cells per microliter. And hypereosinophilia is defined as absolute eosinophil count of more than 1500 with or without end organ damage. If end organ damage is present, the nomenclature changes to hypereosinophilic syndrome. Severe hypereosinophilia, the absolute eosinophil count is usually more than 5000 cells per microliter. The eosinophilia should persist on 2 occasions, at least 4 weeks apart. Talking briefly about the eosinophil maturation, it matures from the hematopoietic stem cell CD34 cells under influence of some transcription factors into immature eosinophil, and under the influence of some cytokines, namely interleukin 3, 5, and granulocyte macrophage colony stimulating factor into mature eosinophils, which under the influence of interleukin 4, 5, and 13, they enter the bloodstream and proliferate in the tissues, leading to tissue eosinophilia. Coming to the etiology of eosinophilia, hypereosinophilia could be due to primary or clonal etiology, namely myeloproliferative variants of hypereosinophilia, which includes acute leukemias, chronic eosinophilic leukemia, and myeloid lymphoid neoplasms with tyrosine kinase domain activation. Or it could be T lymphocyte variant, namely lymphocyte variant of hypereosinophilic syndrome. It could also be due to many secondary causes, which is called reactive hypereosinophilia. Secondary to infection, most commonly fungal infections, helminthic infections, ectoparasitic infestations, atopic or allergy, namely atopic dermatitis, allergic rhinitis, or chronic asthma. Autoimmune causes, namely connective tissue disorders, IgG4 related disease or sarcoidosis. Secondary to some solid tumors, leukemia, lymphoma. It would also result as a consequence of therapy related like radiation or interleukins, or others which includes Addison's disease and cholesterol emboli. There is an entity called idiopathic hypereosinophilia in which no cause is identified for the hypereosinophilia. It could occur with or without organ damage where the etiology is unknown, and it could have many organ manifestations, namely esophagitis, gastrointestinal disorders, or pneumonia. There are some rare causes of familial hypereosinophilia, which includes Viscott-Aldrich syndrome and hyper-IgE syndrome. Now coming to the causes of hypereosinophilia, where the eosinophil count is more than 1500, it could be clonal due to some intrinsic cytogenetic abnormality, namely tyrosine kinase gene activation, or some translocations in some acute and chronic leukemias, or myeloproliferative neoplasms. Or it could result from secondary causes like solid tumors, or due to parasitic infestations, allergy, asthma, or connective tissue disorders. Now, how we approach hypereosinophilia? After a proper history and clinical examination, At first, we screen for some routine workup like liver function test, kidney function test, the peripheral blood smear and retic count, along with general immunoglobulin profile with screening for paraproteinemias, and for special workup for finding the common causes of hypereosinophilia. We rule out parasitic infestations, connective tissue disorders, and organ manifestations of hypereosinophilia by specialized tests like troponin and CKMB for cardiac manifestations, and fungal workup for Aspergillus serologus. And then moving on to specialized causes of hypereosinophilia, we do a bone marrow examination. There we do cytologic evaluation, fish studies, and next generation sequencing. And at last, depending on the localizing features, we do specialized investigations organ wise. Coming to the epidemiology of hypereosinophilia, the prevalence is approximately 1 to 2% in the general population, and a study in a tertiary care center in India showed that the common causes of hypereosinophilia were parasitic followed by allergic, and patients frequently presented with cough as the most prominent symptom, followed by weakness and dyspnea. Another study at a tertiary care hospital studied around 3,440 patients in which severe eosinophilia was found in 0.3% of patients with a male predominance. A prospective study from Western India, which studied around 96 patients, around 12.5% of the cohort had severe eosinophilia, where the common causes was not identified in the majority, which was followed by parasitic and atopy related. The severe cases were found to have a longer hospital stay and higher mortality compared to mild eosinophilia. Now, a prospective analysis of the spectrum of hypereosinophilia and associated clonal disorders found that infections or helmintic infections accounted for 34% of cases of hypereosinophilia, followed by primary or clonal hypereosinophilia, which was further followed by reactive causes. Our patient presented with significant anorexia, which had to be differentiated from the anorexia of aging. So anorexia of aging culminates from an interplay of multiple factors, namely diminished hunger and altered satiety control mechanisms in elderly, which is secondary to decreased ghrelin and neuropeptide Y levels and increased cholecystokinin levels. There is age-related GI motility changes, namely decreased compliance of the stomach, and there is increased gastric emptying time. Multiple contributory factors include depression, financial problems, poor dentition in elderly, loneliness, multimorbidity, and loss of taste and smell, which further lead to the symptom of anorexia, which has many consequences. Namely, it contributes to frailty and sarcopenia, leads to malnutrition, and further increases the risk of mortality. This is a review article which shows the causes of anorexia and proportion of its recovery in older adults. It was found that the most common causes of anorexia was infection related, followed by some benign gastrointestinal diseases, and followed by cardiovascular diseases, which accounted for around 8% of cases. The primary modality of diagnosis in all these cases was CT scan, which followed by blood test, and 78% of patients recovered, and 73% of patients with definite cause, they recovered from their illness. Coming to adrenal insufficiency, there are some special considerations to be taken in older adults, namely the older adults who were diagnosed earlier than age 60 years of age with adrenal insufficiency were actually survivors of congenital adrenal hyperplasia, and those who were newly diagnosed with adrenal insufficiency had mostly secondary or tertiary adrenal insufficiency. Some common etiologies include secondary adrenal insufficiency secondary to pituitary disorders like tumors, prior surgery or prior history of radiotherapy, chronic opioid use for pain management, exogenous steroids intake, and secondary to some drugs like immune checkpoint inhibitors used for the treatment of solid malignancies. Primary adrenal insufficiency is less common, the most common cause being autoimmune adrenalitis and rarely due to adrenal mets. Some diagnostic challenges are elderly usually present with non-specific symptoms like anorexia, weight loss, fatigue, or nausea, which could be related to age-related changes, but it could also suggest underlying adrenal insufficiency. Adrenal insufficiency also present with postural hypotension,
due to decreased mineralocorticoid effect, due to decreased mineralocorticoid action, which could be misattributed to aging or drug related, and confusion or delirium may mask adrenal crisis. These are the types of adrenal insufficiency. Primary adrenal insufficiency indicates that the adrenal gland is not producing enough mineralocorticoids and glucocorticoids, which manifests with increased ACTH and decreased aldosterone, and hyperpigmentation secondary to increased ACTH, which was not present in our case. Secondary adrenal insufficiency implies pituitary disease leading to decreased ACTH secretion with normal mineralocorticoid axis. In tertiary adrenal insufficiency, it is due to hypothalamic cause or chronic steroid use, decreasing the release of CRH from the hypothalamus, leading to normal or decreased ACTH. In our cases, chronic topical steroids with possible role of azathioprine led to decreased CRH production from the hypothalamus, leading to normal ACTH and decreased cortisol levels. Coming to adrenaline, our patient presented with hypereosinophilia due to secondary adrenal insufficiency. Cortisol suppresses eosinophil count by 3 mechanisms, majorly promoting eosinophil apoptosis and decreases the bone marrow production of eosinophils and shift of eosinophils from intravascular to tissue space. Eosinophilia is usually mild to moderate, ranging from 500 to 1500 per microliter in adrenal insufficiency. Our case had more than 5000 at presentation, which could be due to chronic cortisol deficiency related to chronic use of topical steroids and due to additional immune stimulation. He being a case of chronic eczema with on and off intake of oral steroids and elevated IgE levels at presentation. Some comparison with existing literature. These cases studied eosinophilia secondary to adrenal insufficiency. Most cases were less than 60 years with primary or secondary adrenal insufficiency at diagnosis, and all had mild to moderate eosinophilia. Our case contrasts in several ways. Our case had absolute eosinophil count of 6,420, which seems probably the highest reported absolute eosinophil count according to River literature. He also had tertiary adrenal insufficiency due to chronic topical steroid use with resulting hypothalamic pituitary adrenal axis suppression, and was steroid responsive as shown in previous slides, that the eosinophil count dropped to less than 100 after starting of IV hydrocortisone followed by oral steroids. Thank you. I would like to give special thanks to the Department of Endocrinology, Department of Dermatology, Department of Radiology, and Department of Nuclear Medicine for their contribution.
Thank you, Dr. Venu and Dr. Naveen, for the presentation. So the main intention of presenting this case was not for the rarity of the case first, because it's not, but rather to highlight the challenges faced due to the complexity of presentation. Because an elderly man who presents with only loss of weight and loss of appetite, no other complaints, and also with a low backache, one of the earlier things that we usually consider in such individuals is hidden occult malignancy. We do not want to miss them out, and we also saw it in our CGR on geriatric oncology. They are quite common, and also the presence of this severe hypereosinophilia again made us focus more towards trying to rule out presence of whether it's a myeloproliferative disorder or could it be a solid organ malignancy such as CA colon, CLM, which can present with low backache, loss of appetite, as well as severe hypereosinophilia. But then here we see, because of presence of multiple coexisting conditions such as lumbar canal stenosis, prostatic hypertrophy, it makes it a little more challenging for us to come to a definitive conclusion. Hence, the endocrine condition was considered later on during the course of the management than earlier on in him, because he neither had hypertension, he didn't have any skin pigmentation, even his eczema was actually not having any symptoms. It's a chronic past history. We even took dermatology consultation. They said it is a resolved case. We do not have to even treat it at the moment. So these are the challenges that we faced while trying to manage this case.
Before we go on to the question, I really want to thank all who helped us solve this case, including the support we received from the radiology department, nuclear medicine, dermatology, and also the endocrinology department in trying to help diagnose this and improve. Thank you so much. Sir, any comments from Vic, sir? Sir, please.
Topical corticosteroid, you're saying he correctly doesn't work. When was the last time he applied corticosteroid? How much was he using? Which preparation was he?
Topical clobetasol he was using. And he was taking some alternate medications also, sir. There may be some possibility of steroids also there.
How much? Because we need to know these things. There's a lot of variation in the potency of topical corticosteroids. And if you're using small amounts, if you have a single patch on your eye as an adult, it's about 1% or 1.5% of body surface area. So it's very difficult to apply enough topical corticosteroid to suppress your hypothyroidism. The other reason why I think that's unlikely is that as soon as you gave him oral corticosteroids, his eosinophils came down, which means he was not getting enough exogenous corticosteroids to suppress the eosinophil. So clearly that can't be the reason for the eosinophil. So he certainly has hypocortisolism. But I don't know if you can attribute it to the topical corticosteroid. If you're thinking that he's taking corticosteroids from some other source, that again needs you need to explain why those corticosteroids did not suppress his eosinophils, whereas as soon as you gave him tablets of prednisolone, his eosinophil function.
Yes, sir. Because his baseline, we on history we got that lab parameters, sir, that before 2 months his eosinophil count was normal. Absolute eosinophil count was only 10. That on July 2025, he outside evaluated for some baseline medicine, which showed a normal eosinophil. We also had that same doubt, sir, whether it hypereosinophilia was from initially or it's a recent onset. But before 2 months, that showed a normal eosinophil. So we thought. Thank you.